Dilation with polyethylene balloons inserted through the working channel of the endoscope is indicated in treating symptomatic stenosis, primarily associated with Crohn's disease, in order to increase the caliber of the intestinal lumen. This type of balloon achieves a uniform radial distribution of the dilation force. The balloons are oval-shaped and vary in diameter between 6 and 25 millimeters and are inflated with saline solution until reaching pressures of 3 to 5 atmospheres, in which the use of preassembled balloons is advised. Once the stenosis is reached with the endoscope, the balloon is passed through the working channel and the guide slides through the balloon and smoothly passes through the stenosis, enabling the balloon to pass afterwards and preventing laceration of the intestinal wall. Sometimes radiological control may be necessary in order to know the characteristics of the stenosis or control the passage of the guide in very significant stenoses. The balloon becomes situated inside of the stenosis, making sure that the midpoint of the balloon remains in the critical point. It can be useful to stabilize the balloon before inflation by anchoring the catheter sheath against the endoscope. The initial caliber of the balloons must be similar or slightly smaller than the estimated diameter of the stenosis. The most widely used technique is based on the use of multi-diameter balloons with controlled radial expansion, which reach 3 consecutive diameters by way of pressure control. Inflation begins with the smallest diameter and maintaining it for between 30 seconds and 1 minute before progressing to the next caliber, observing the appearance of significant mucosal tears during the process. There is no data that shows that a longer dilation time is more effective. It is advised to perform 3 consecutive dilations per session, which can be repeated in a series of sessions until the objective is reached. Usually 2 or 3 dilation sessions are required, with an interval of a few days in between if the obstruction is acute, or several weeks if the occlusion is more chronic. Generally, 2 objective balloon calibers are considered, one with a diameter of up to 25 millimeters, or the other up to 18 or 20 millimeters, with the latter having less complications. Once the maximum balloon diameter for a session is reached, provided that the balloon is slightly larger than the endoscope used, the endoscope attached to the balloon as a unit can be advanced through the stenosis, keeping constant pressure. This maneuver can help to pass through a slightly angulated stenosis or stenosis with poor field visualization. Generally, a dilation that allows the passage of a 13 mm endoscope is considered effective dilation. In certain circumstances, the use of certain techniques may be useful in the dilation maneuver, such as injection of corticoids or other substances in the lesion, or performing several radial cuts using the needle-knife sphincterotomy. The most significant complications of the technique are perforation, which occurs in 0.4% of the cases, and hemorrhage, which generally subsides spontaneously. If necessary, pressure can be exerted with the inflated dilation balloon, and hemostasis clips used if any arterial bleeding is observed.